Hey, altruistic followers and well wishes. I presume you and your blood are hale and healthy. It is social activist come good-hearted preacher, Professor Ash back with the sheer ecstasy for my 121st video on annual of publication on YouTube today, 4th January 2021 month. This is my first video for this year. Okay, I published 120 videos in 2020, previous year already. The topic for today is medical errors, causes and prevention. A medication, also known as medicine, pharmaceutical drug, or simply drug, is a drug used to diagnose, cure, treat, or prevent disease. Drug therapy, pharmacotherapy is an important part of the medical field and relies on the science of pharmacology for continual advancement and on pharmacy for appropriate management. Drugs are classified in multiple ways. One of the key divisions is the level of control which distinguishes prescription drugs or on the order of a physician, physician assistant, or qualified nurse from over-the-counter drugs, those that consumers can order for themselves. Another key distinction is between traditional small molecule drugs, usually derived from chemical synthesis, and biopharmaceuticals, which include recombinant proteins, vaccines, blood products used therapeutically, such as IVIG, gene therapy, monoclonal antibodies, and cell therapy. Other ways to classify medicines are by mode of action, route of administration, biological system affected, or therapeutic effects. An elaborate and widely used classification system is anatomical therapeutic chemical classification system, ATC system. The World Health Organization (WHO) keeps a list of essential medicines. Governments generally regulate what drugs can be marketed, how drugs are marketed, and in some jurisdictions, drug pricing controversies have arisen over drug pricing and disposal of used drugs. Medications are offered by health services throughout the world. However, with substantial and increasing medication use, there is a growing risk of harm. This is compounded by the need to prescribe for an aging population with increasing complex medical needs and the introduction of many new medications. These issues are particularly relevant in primary care. In many cases, prescribing is initiated in primary care, and those initiated in the hospital may also be continued in primary care. A substantial amount of literature about medication errors is based on the hospital setting, but there are differences in the type of clinical problems encountered. Classes of medications used in the organization of services in primary care. This means that the risks posed in primary care and the solutions required may differ from those in hospital settings. The US National Coordinating Council for Medication Error Reporting and Prevention defines a medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. There are a number of different approaches to classifying medication errors. One approach is to base the classification of the stage in the sequence of medication use process, such as prescribing, transcribing, dispensing, administration, or monitoring. Another approach is to consider the types of errors occurring, such as wrong medication dose, frequency, administration route, or patient. A further approach classifies errors according to whether they occur from mistakes made when planning actions or errors in the execution of appropriately planned actions. Errors may also be classified according to the level of severity. These approaches are not mutually exclusive, and there is no strong evidence to support particular methods of defining or classifying errors, specifically in primary care. The approach taken will depend on the setting and the purpose of the classification. Estimating the prevalence of medication errors is difficult due to the varying definitions of classification systems you employ. Rates can vary depending on the denominator used. The challenge is compounded by variations in healthcare system organization and the availability and use of incident reporting systems. Undesirable outcomes include adverse drug reactions, drug-drug interactions, lack of efficacy, suboptimal patient adherence, and poor quality of life and patient experience. In turn, these may have significant health and economic consequences, including the increased use of health services, preventable medication related hospital admissions, and death. It has been estimated that in some countries, approximately 6 to 7% of hospital admissions appear to be medication related, with over two-thirds of these considered avoidable and thus potentially due to errors. The problem is likely more pronounced in the elderly because of multiple risk factors, one of which is polypharmacy. A number of studies have examined factors associated with the medication errors. Commonwealth Fund International Health Policy Survey compared factors associated with the patient-reported medication errors across 7 countries. In 11% of patients experiencing a medication error, risk factors included poor conditions of care, cost-related barriers to medical services or medicines, multimorbidity, and hospitalization. Other studies have found that medication errors are associated with the increasing number of medications, childhood and older age, and specific medications and medications for certain disease states. Factors that may influence medication errors, factors associated with the healthcare professionals, lack of therapeutic training, inadequate drug knowledge and experience, inadequate knowledge of the patient, inadequate perception of risk, overworked or fatigued healthcare professionals, physical and mental emotional health issues, poor communication between healthcare professionals and with the patients, factors associated with the patients, patient characteristics, complexity of clinical case, including multiple health conditions, polypharmacy, and high-risk medications, factors associated with the work environment, workload and time pressure, distractions and interruptions, lack of standardized protocols and procedures, insufficient resources, issues with the physical work environment, factors associated with the medicines, naming of medicines, labeling and packaging, factors associated with tasks, repetitive systems for ordering, processing, and authorization, patient monitoring, factors associated with the computerized information systems, difficult processes for generating list first prescriptions, difficult process for generating correct repeat prescriptions, inadequate design, lack of accuracy of patient records, inadequate design that allows for human error, primary secondary care interface. I want to tell you something, computer is a dumb machine. Like some of the idiots that program it, or say that I am the systems analyst, whatever. It's not the problem with the computer really. Computer is a dumb machine, as I said. People are dumb. They don't think through properly. They don't design the system properly. They don't write the codes properly. They don't test it properly. Primary secondary care interface, limited quality of communication with the secondary care, little justification of secondary care recommendations. Medication review is a process of patients' medicines evaluation in order to improve the health outcomes and mitigate the drug-related problems. A systematic review of 38 studies of primary care interventions designed to reduce medication-related adverse events found that most successful interventions included a medication review conducted by a pharmacist or other clinicians, or focused on multi-component interventions which are a medication review by a primary care professional as one component. Studies showed that pharmacist-led medication reviews reduced hospital admissions. Medication reconciliation is a formal process of establishing and documenting a consistent, definitive list of medicines across transitions of care and then rectifying any discrepancies. Increased medication discrepancies at discharge are associated with an increased number of prescribed medications, underscoring the need to address polypharmacy as a multifaceted threat to patient health. The accuracy of medication information on discharge summaries is generally poor. Computerized provider order entry with a decision support may be effective if targeted at a limited number of potentially inappropriate medications and is designed to reduce the alert burden by focusing on clinically relevant warnings. There is substantial evidence which supports the use of CPDE, that is computerized provider order entry, to decrease the frequency of medication errors. by inpatient setting. One study found that the likelihood of error occurrence was decreased by 48% when an order was processed via CPD. Educating healthcare providers is a key element to improving safety in primary care. This holds true in reducing medication errors, where education is often part of multi-component interventions. Evidence regarding medication management education targeted at patients is lacking, but it is an important area for exploration. A review found that some evidence that patient self-administration of medication can be as safe or safer than usual care following appropriate education and preparation. The same review found that patient health, personal health records often had a positive effect on health outcomes, although there was a potential for a negative impact on equity. Injection use may be associated with errors not applicable to oral preparations. A primary concern is the risk of infectious disease transmission. I don't know how they are going to do this vaccine, this thing. Almost the whole, all the people in the world need to be vaccinated, not once, twice. That too, I don't know how they are going to do it in developing, underdeveloped countries like India, where corruption is so high here. Politicians do not care about the people. It's all anti-people government, I would say. Okay, at the state level, central level, whatever, all politicians are rotten to the core. Results from the WHO Global Burden of Disease study estimated that unsafe medical injections led to 340,000 human immunodeficiency virus, HIV infections. 15 million hepatitis and infections, hepatitis B infections, and 3 million cases of bacteremia in 2008. Other errors associated with the injection use include mistakes in weight-dependent dosing, incorrect reconstitution, including the wrong concentration or inappropriate diluent, wrong route of administration, and problems with the storage. Other issues related to injection use include the need for hepatitis B vaccination of health workers and adequate facilities and training for the safe disposal of used injection equipment. That is another area. So many hospitals discard the medical waste, even surgery waste, along with the household waste in countries like India. What's the government doing about these things? Medication, it has been reported also by the media, but again and again it continues to happen. What does it prove? Corruption. Medication use in children presents some additional challenges. The off-label and unlicensed use of medicines is widespread, which may increase the risk of avoidable medication-associated harm. A small error in dose of medication given to children has a greater risk of harm compared to the adult population. Pediatric prescribing also requires weight-related dose adjustment and other dosing calculations, which are less commonly encountered in adult prescribing. Primary care providers may feel that they do not have time to properly check doses in relation to a child's weight, which is subject to change over time and thus has a potential to lead to inaccurate prescriptions being written and dispensed. Liquid medication in children is also likely to be required. Reports suggest that over 40% of carers make errors when dosing liquid medication. Medication errors are particularly important given the large and growing global volume of medication use. This is particularly critical in primary care, where a significant proportion of prescribing occurs. A number of factors may contribute to errors in primary care, including those pertinent to the healthcare professionals, patient, work environment, medicines as a product, tasks, computerized information systems, and primary secondary care interface. This presents a range of opportunities of interventions in terms of reducing error rates. Those provided by clinical pharmacists are promising approaches. Strategies to reduce medication errors in primary care: educating medical care providers and patients, educating primary care providers about common causes of medication errors, providing simple tools to assist primary care providers in safe medication prescribing and use process, considering how patients can be actively involved in medicine management, providing patient engagement tools to address non-adherence, implementing medication reviews and reconciliation, ensuring that pharmacists actively review prescriptions. There are only any pharmacists in most of the pharmacies. It is run by with uneducated urchins, street urchins, who do not have any idea about the medicines. I'm sorry to say that. They get the license to open a pharmacy, by applying. When they apply, it will be a qualified pharmacist, but operation is with the street urchins, uneducated, illiterates. Encouraging and supporting use of medication reconciliation by clinicians using computerized systems, strengthening electronic prescribing and alert systems. Computerized provider order entry, data entry, and with the decision support may be particularly effective when targeted at a limited number of potentially inappropriate medications and when designed to reduce alert burden by focusing on clinically relevant warnings. Prioritizing areas for quick wins, target use of injections as a key source of errors, target interventions related to the care of children and elderly, implement multi-component interventions with a mix of education, health informatics, medication reviews, and involvement of community pharmacists. Transfer specialist outpatient clinics for the prescription of selected medications that require routine monitoring, such as warfarin. Conduct further research on medication errors to develop a better understanding of the causes, generate evidence for interventions impacting on adverse outcomes, and to help bridge knowledge of gaps in low and middle income countries on injection use and the science specialties of the pediatric population. Primary care services are at the heart of healthcare in many countries. Primary care, secondary care, tertiary care. Okay, they provide an entry point into the health system and directly impact on people's well-being and the use of other healthcare resources. Unsafe or ineffective primary care may increase morbidity and preventable mortality and may lead to the unnecessary use of scarce hospital and specialist resources. Thus, improving safety in primary care is essential when striving to ensure universal health coverage and the sustainability of healthcare. Safer primary care is fundamental to the United Nations Sustainable Development Goals, particularly to ensure healthy lives and promote well-being for all at every age. Understanding the magnitude and nature of harm in primary care is important because a significant proportion of healthcare is offered in this setting, yet there is little clarity about the most effective ways to address safety issues at this level. List of 10 key actions that are likely to have the most impact on improving safety in primary care. Set local priorities, take a wider systems approach to improving safety, communicating the importance of safety in primary care, focus on building a positive safety culture, strengthen ways of measuring and monitoring patient safety, strengthen the use of electronic tools, involve patients and family members, strengthen workforce capacity and capability to improve safety, focus on those at higher risk of safety incidents, celebrate successes and share learning with others. Medication errors are any preventable events that may cause or lead to inappropriate medication use or patient harm. This is the definition of the National Coordinating Council for Medication Error Reporting and Prevention, NCCMERP. Medication is in the control of the healthcare professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging, nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. Medication errors can be categorized into the following classes. An omission error occurs when a dose is not given or when the next dose is due and the previous dose was not given. A wrong dose error occurs when the dose is given in either below or above the correct dose by more than 5%. An extra dose error occurs when a patient receives more dose and was prescribed by the prescriber. A wrong dose form error happens when any dose form or formulation is given to the patient that is not the accepted interpretation of the prescriber. For example, a drug is given by mouth for a drug order as an intramuscular injection. A wrong time error occurs when any drug is given 30 minutes or before or after it was prescribed up to the time of the next dose. Another way of categorizing medication errors is to define them by what caused the failure of the desired result. This helps in clearly identifying the cause of the error. This classification is human failure. These are failures that occur at an individual level. Human errors include those made by the patient, such as non-compliance to the prescribed drug therapy. They can also be caused by the technician, such as no cross-referencing. Technical failure, this is a failure that results from location or equipment. That is failure to properly operate automated equipment. Organizational failure is a failure due to organizational rules, policies, and procedures. Root cause analysis of medication errors. This refers to a logical and systematic process used to help identify what, how, and why something happened in order to prevent recurrence. Identification of specific potential causes allows a person to take specific actions to prevent potential error. Actions are then taken to improve the quality of work being done and therefore improve patient outcomes. Causes of medication errors: assumption error occurs when an essential piece of information cannot be verified, therefore an assumption is made, especially at the pharmacy. A selection error or by the nurse administering the injections and all that. Okay, a selection error occurs when there are two or more options available and the wrong option may be selected. A capture error is the one that occurs when focus on the task is diverted elsewhere and therefore the distraction captures the person's attention, preventing the person from detecting the error or causing the error to be made. Physiological causes: each individual is generally unique and the rate at which a person can metabolize drugs from the body varies greatly. For instance, G6PD is an enzyme that helps to remove medications from the body. A patient with this enzyme deficiency taking medication that depends upon this enzyme of metabolism could result in serious harm or even death. Social causes are kind of failures to follow medication instructions because of cost, non-compliance, or misunderstanding of the instruction, forgetting to take the medication, taking too many doses, dosing at the wrong time, not getting the prescription filled or refilled in a timely manner. Patient response: most patients have the intended response to a prescriber expects from the medication selected. However, an individual's unique physical and social circumstances make it impossible to predict which medication may result in no substantial harm and which may result in death. Similar product name, example, quinidine, clonidine, cisplatin, and carboplatin. Abbreviations, example, QID or QOD. Poor illegible handwriting leading to assumptions, labeling and packaging, miscalculation and improper dosage, medication order which is written on the wrong patient's chart. And this happens in hospitals. Sometimes they operate on the wrong patient also. Wrong route, patient, time, failure to document the drugs administered by a patient. Another provider that then checks the medication chart and sees no medication and gives the patient another second dose. Poor patient assessment without attention to the areas covered in medication history. Carelessness. Complication due to drug incompatibilities, a poor working environment like job stresses, excessive noise, poor lighting, excessive heat, constant interruptions. Nowadays, the cell phone is a damn idiotic instruction. Poor attitudes by healthcare workers, access of drugs by non-qualified persons, especially, all these social, so-called social interaction websites should be completely banned, like WhatsApp, Facebook, Twitter, Tinder, whatever. Patients even take their family member, friends, medication. Lack of patient information, such as incomplete patient information with no patient allergies, other medications the patients are taking, previous diagnosis and previous lab results. Lack of information to the prescribers due to unavailable drug information, such as updated drug warnings. The wrong diagnosis can lead to inappropriate treatment, errors in interpreting the lab results, too many telephone calls, work overload and staff burnout, lack of patient medication, counseling. Cell phone is a damn distraction, more of a burden. Negative effects, outweigh the positives. There is no necessity for a cell phone. Landline phones are okay, that will do, that serves a purpose. Medication error prevention, patient education, both the patient and the caregiver need basic knowledge to administer, handle, and support safe medication use. Patients should understand the key pieces of information about every medication taken. The cell phone addiction is a big addiction, more than substance use addiction or alcohol, tobacco use, whatever. Patient education assists patients in becoming more informed and empowers them to be advocates of their own safety. Innovation to promote safety, adequate space and clean, well-lit conditions are just some of the basics. These minimize the possibility of medication errors. Automate and barcode fill procedures, maintain clean, organized and orderly work areas, provide adequate storage areas with clear drug labels on the shelves, provide adequate computer applications and hardware. Break them, throw them in cooler. Repeat verbal orders such as spelling the drug name aloud and speak slowly and clearly. Have the indication of purpose for use with each product. And medical transcription errors are also very common. Doctors don't create the files, medical files, they dictate, and it is typed by some illiterate medical transcription errors that arises leads to medical transcription errors. Avoid dosage abbreviations and product abbreviations. People have become very lazy. Always read the label 3 times and check with the medication order before administering the medication. Use 5 rights of drug administration. Never use trailing zeros with the medication orders. And transcription orders. Example 25 instead of 25.0. In doubt, always check order with the prescriber, a pharmacist, or the literature. Do not assume anything. Do not try to decipher illegibly written orders. Always be alert. Never be too easy to stop, learn, or inquire. I am smiling because all these things happen in countries like mine, India. Encourage the use of brand names and generic names with orders for medications. Question the medication if the patient states. I have read in US also that things are totally different. The consumer protection is very good. Whereas in countries like India, there is hardly any consumer protection. Rules are there on paper, but it's not enforced. It's as good as not having any rules. That it is not what I usually take, etc. Steps to take with the medication administration errors. Check the patient by assessing all parameters. Example, vital signs and documents accordingly. Assess for the effects of the drug. Incomplete medication error report forms after contacting the physician and nurse in charge. Monitor patients accordingly. Think and act critically. Modify the nursing practice to prevent further errors. Do not leave the medication by the bedside. Use the reliable formula for calculating doses. Take precautions in high-risk group. Example, pregnant, elderly, and pediatrics. Application of Lean Six Sigma technique in hospitals is proven to be effective in reducing medical errors in hospitals. The process of medication administration at a hospital involves 6 steps: selecting and procuring, storing, ordering and transcribing, preparing and dispensing, administering the medication, monitoring medication effects. To establish a context for identifying the medication omission errors or medical administration records at the hospital, here is an outline of the process sequence. Daily orders are faxed to the pharmacy where they are profiled on the MAR, medical administration records. Nurses review the MAR and report any error findings to the pharmacy. Pharmacy technician then records the errors by type and who committed them. In this arrangement, it is very difficult to capture errors such as forgetting to fax orders which are committed by the nurses themselves. The pharmacy is thus blamed for every error, and there is no accountability at the nurses' end for more errors. Nurses' duty time should also be reduced. In most of the hospital, nurses work for 12 hours at a stretch. They are also human beings. Okay, they have to be focused in the work. That doesn't happen when they have to work 12 hours at a stretch without any break, treating them like animals. Even animals are treated much better. There are so many organizations protecting the animal rights. PETA, GITA, Blue Cross, People for Animals. Another pertinent and vital metric, albeit elusive, is the average order cycle time. This is defined as average time it takes a pharmacist to fill an order, measured from when a physician writes a prescription to when it registers on the MAR as correct. The Six Sigma techniques use statistical procedures and 5 well-defined phases of the define, measure, analyze, improve, and control. DMAIC, roadmap to achieve profitability and quantum gains in quality, sometimes as a result of redesign of the process maps and installation of the new equipment. In healthcare, the best approach appears to be error prevention using software that flags mistakes, so employees will take immediate corrective action. Awareness of deficiencies in patient safety has arisen internationally. Patient safety is considered to be a global public health issue, imposing a substantial burden on the world's population. It has been estimated that 1 in 10 hospitalized patients is harmed when receiving healthcare in industrialized countries, and half of these may be preventable. Medication errors can occur during various stages of the medication use process. Example, while prescribing, dispensing, or administering a medicine. The majority of these errors are preventable and caused by system factors. One of the recommended strategies to learn from medication errors and risk-prone processes is the establishment of a local and national medication error reporting (MER) systems. MER systems are typically databases where healthcare professionals are able to find reports on medication errors in their daily practice. This data can be further analyzed and used for improving the detected process, producing errors in healthcare units. There are specific high-risk groups that need to be considered for medication errors. For pediatric patients, points to consider include ensuring that it is clear from what age the product can be used, plus dosing calculations, which can be complicated if dosing is based on body surface area, for example, rather than a fixed dose. For elderly patients, polypharmacy and the possibility of patients receiving contraindicated medication unintentionally should be considered, as well as issues and with the patients being able to read the information that comes to them. Patients with a visual impairment are most likely to need eye drops, and the front size needs to be examined to avoid medication errors. Consideration should be given to the use of braid. As with all risk minimization activities, the effectiveness of the activity needs to be assessed with a well-defined process and outcome indicators to measure against for further risk minimization. National reporting systems that collect data on medication errors and outcome data can be used for this, as can spontaneous reporting, which is the most common. The incidence and potential for causing injury are significantly higher for medication errors among pediatric patients than adult patients. Okay, for seniors like me who are 60 plus, it's a problem even tearing the aluminum foil and getting the tablet out, because the tablet is too small. It's very tough to tear the aluminum foil. It's all packed as a strip, aluminum strip. That is one thing. So many times you cannot open the cap. It is so damn difficult. And even the printing should be in bold letters, capital. Okay, big size, so that people can see clearly. It is ascertained that the rate of pediatric medication errors, people don't think of these things. That it is convenient for use. Whereas in US, they don't dispense the medicines in bottles, in strips, aluminum strips and all that. It's all, they put it in a small plastic, I would say a box or a bottle, which is very easy to open. The tire is very easy to open, like a lift-off type. That is very convenient even for the elders, kids, whatever. Actually, it should be child-proof, I'm sorry. Child-proof, tamper-proof. This is thought to reflect both the physiological and developmental features of children. Developed countries have so many good practices. Those things are not, followed, emulated. Only the wrong practices are emulated. Children, as well as the lack of accurate medication dosages for pediatric patients. Multiple steps are involved in determining the type and dosage of medication to be administered. These include the primary prescription, the request for supply, receipt of the request, identification and retrieval of the material requested, and supply to the practitioner, administration and monitoring at further levels of complexity. Medication errors in drug administration predominantly take place during prescribing, although errors commonly take place involving incorrect diagnosis, incorrect dosing, the wrong patient, and incorrect drug selection. Secondary medication errors are associated with inappropriate administration of the correct drug. These include errors of route of administration, dosage, timing, patient identity, failure to administer the drug, improper placement of infusion pumps, and absence of recording of drug administration. The most frequent errors of medication administration are failure to administer the drug and incorrect drug scheduling. Several factors contribute to the high rates of medication errors in pediatric patients. These include failure to read the prescription, distraction, high patient-nurse ratio, and the availability of drugs with a similar name to the drug prescribed. Medication errors can occur both as a result of human mistakes as well as from systemic errors, and this complicates effective monitoring of drug administration. It is, however, recommended that whenever a medication error has taken place, the details of mistake should be provided to the relevant supervisor, and And such notification is important for understanding the causes of the errors and allow steps to be taken to reduce such errors in the future. Medical errors that predominantly include errors associated with the drug administration are potentially avoidable. Nurses are in a special position regarding assurance of patient safety and avoiding medication errors, and the perspectives on patient safety warrant careful consideration. In the present study, we compiled and analyzed the opinions of pediatric nurses regarding the causes of medication errors. Methods used for error notification and avoidance of such errors. Nurses most commonly cited long working hours, high patient-nurse ratio, lack of appropriate guidelines for drug administration to pediatric patients, insufficient knowledge of the medication, and inaccurate or poor quality reading of the prescriptions as the primary causes of medication errors by pediatric nurses. One of the pediatric nurses sampled 50% cited distraction as a major cause of medication errors. In addition to errors recording the prescribed drugs and difficulties interpreting the handwriting of the prescribing practitioners. Nurses themselves have problems. Nurses have some medical knowledge. Nurses thereafter included the patient-nurse ratio, 37%, the exact quantity dosage of medication to be administered. Just think of the situation with the so-called medical transcriptionist. Medication to be administered 35% in the absence of double check of medications, 28% among the causes of medication errors. Insufficient communication with the personnel, order of magnitude errors in numbers followed by multiple zeros or with fractional numbers, unreadable handwriting, and distraction during preparation or administration of medications. Availability of drugs with similar names, dosage assessment, and lack of knowledge were including the causes of medication errors. Lack of dosage guidelines for pediatric patients and workload were singled out among the most common causes of medication errors. These findings are supported by the results of the present study. In another study, higher patient-nurse ratios and longer working hours adversely affected the working environment, leading to distraction, reduced quality of care, and medication errors. In addition, the availability of different preparations of the same drug combined with the diverse formulations for pediatric and adult administration were reported to increase the risk of error. Future studies addressing avoidance of errors in pediatric medicine should therefore focus on nurse overloads and on developing appropriate guidelines for the use of specific medications in a pediatric setting. The rate of medication errors is largely governed by human factors that, despite current developments in informatics and computer technology, are not easily amenable to monitoring. Errors in medication administration compromise patient safety and can increase morbidity and mortality. Pediatric patients are relatively vulnerable compared to adults, reflecting their incomplete physiological development, and children are therefore more likely to be adversely affected by medication errors. Pediatric nurses have a key role in monitoring, notifying, and avoiding medication errors. The perspectives of pediatric nurses regarding medication errors is therefore an important foundation point for developing strategies to avoid medication errors. Overall, diagnostic errors are estimated to occur in 10 to 20% of patients. In errors are most common in fields such as emergency and internal contrast. Errors are less common in specialties, 2 to 5% in specialties such as radiology and pathology, which primarily depend on pattern recognition. Types of medical errors: diagnostics, error or delay in diagnosis, failure to employ indicated tests, use of outmoded tests or therapy, failure to act on results of monitoring or testing, treatment, error in the performance and operation of an operation procedure or test, error in administering the treatment, error in the dose or method of using the drug, avoidable delay in treatment or in responding to an abnormal test, inappropriate care, preventive, failure to provide prophylactic treatment, inadequate monitoring or follow-up treatment, others, failure of communication equipment failure, other system failure. Cognitive errors occur because of flaws in the thinking of the clinician. When a medical error is made, it is unlikely that a single factor in isolation is to blame. Most errors are multifactorial in origin. This model is sometimes called Swiss cheese model. All of you like cheese, right? Like the rats of action causation, which posits that an error occurs when flaws in safety barriers perfectly align to allow the error to occur. Cognitive biases are systematic, unconscious, automatic patterns of thought that sometimes distort thinking and potentially lead to errors. Nearly 200 such biases have been described, though there is no formal list. They can be divided into several different categories: decision-making, behavioral biases, social biases, memory errors, and biases in probability and belief. Many cognitive biases originate from the use of heuristics, which are unconscious mental shortcuts to problem solving. Heuristics are essentially rules of thumb. Heuristics and biases are not necessarily bad in and of themselves, especially in situations where there is little time for deliberate thought. In fact, they are absolutely necessary. It would be impossible to live an entirely rational life coolly weighing the ups and downs of every single decision we must make throughout the day. Heuristics plays an important role in medicine. An experienced clinician may often use her knowledge to rapidly assess a patient, render an accurate diagnosis, and start the appropriate treatment. In an emergency, clinicians must use heuristics, trial and error. When a patient presents with a chest pain or the sudden onset of weakness, clinicians do not have the time to deliberate. Dr. Charles Carey divided cognitive biases in medicine into several categories. Errors of over attachment to particular diagnosis, anchoring, confirmation bias, premature closure, sunk costs, errors due to failure to consider alternative diagnosis, multiple alternative bias, representativeness, restraint, search, satisfying, unpacking principle, errors due to inheriting someone else's thinking, diagnosis, momentum, framing effect, and bandwagon effect, errors in prevalence, perception, or estimation, availability bias, ambiguity effect, base rate neglect, gambler's fallacy, hot hand fallacy, in hindsight bias, playing the odds, posterior probability error, order effects. Errors involving patient characteristics or presentation context, fundamental attribution error, affective bias, in-group bias, triage queuing, contrast effect, yang out, errors associated with physician effect, personality or decision style, commission bias, omission bias, outcome bias, visceral bias, overconfidence, belief bias, ego bias, sunk cost, zebra rhetoric. Medication errors can occur in choosing a medicine, irrational, inappropriate, and ineffective prescribing, under-prescribing or over-prescribing, writing the prescription errors including illegibility, manufacturing the formulation to be used, wrong strength, contaminants or adulterants, wrong misleading packaging, dispensing and formulation, the formulation, wrong drug, wrong formulation, wrong label, administering or taking the drug, wrong dose, wrong route, wrong frequency, wrong duration, monitoring therapy, failing to alter therapy when required, erroneous alteration, and adverse effect is any abnormal sign, symptom, or laboratory test, or any syndromic combination of such abnormalities, any untoward or unplanned occurrence, or any unexpected deterioration in a concurrent illness. If an adverse event occurs while an individual is taking drug, it could be adverse drug reaction, ADR. The term adverse drug event is sometimes used to describe this, but it is a bad term and should be avoided. Wrong term. If an adverse event is not attributed to drug, it means it remains an adverse event. If it may be attributable to a drug, it becomes suspected ADR. In ADR, adverse drug reaction is an appreciably harmful or unpleasant reaction resulting from an intervention related to the use of a medicinal product. Some medication errors result in ADRs, but many do not. Occasionally, a medication error can result in an adverse event that is not an ADR. There are 4 broad types of medication errors: knowledge-based errors, rule-based errors, action-based errors, and also known as SLIPs, memory-based errors, also known as lapses. Mistakes: knowledge and rule-based errors, SLIPs, action-based errors, and lapses, memory-based errors are being called active failures. However, there are several properties of systems, so-called latent factors, that make prescribers susceptible to error. Among doctors, depression and exhaustion are important. Errors are more likely to occur when tasks are carried out after hours by busy, distracted staff, often in relation to unfamiliar patients. There is a particular risk of errors when doctors first arrive in hospitals, especially on Monday Blue, because of shortcomings in the knowledge and presumably also because they are unfamiliar with the local prescription charts and other systems. Improved education and improved working conditions, including better induction process, should reduce the risk of errors Due to these factors, a national prescription form would help. One difficulty in detecting errors is that those who make them fear in disciplinary procedures and do not want to report the, the establishment of blame-free, non-punitive environment can obviate this. The reporting of errors, including near misses, should be encouraged using error reports to identify areas of likeliest occurrence and simplifying and standardizing the steps to the treatment process. However, some systems for voluntarily reporting medical errors are of limited usefulness because reports often lack details and there is incomplete reporting and under-reporting. A medication error reporting system should be readily accessible with clear information on how to report a medication error, and reporting should be followed by feedback. Detection may be improved by using a combination of methods. One has to learn from past mistakes. It may not be our own mistakes. We can learn from others' mistakes. This is especially vital in medical field. Self-medication is absolutely wrong. In countries like India, people go to the nearby pharmacy and explain the condition to the person at the counter in a pharmacy. This guy, who is not a qualified physician, suggests some medicines based on sheer experience. And people buy those thinking that they are very smart, saving on physician consultation fees. They are penny wise but pound foolish. So many doctors' prescription is not easily decipherable, illegible. I really wonder how the guy manning the counter at the pharmacy dispenses the medicines. Medicines are a perishable commodity like edible or products. So many times, even expired medicines are sold in pharmacies either by changing the expiry date or not by issuing a bill with the batch number and expiry date of medicines dispensed, besides other requisite details as per the rules. People also should be blamed since they never insist on a bill and do not buy the whole pack, which will have such vital details. Some pharmacists also play tricks saying if they need a bill, they'll have to pay taxes. The fact is, tax is already included in so-called MRP. MRP is not maximum manufacturer's rate, it is a maximum retail price. So the product should be sold much below the MRP. How many people are aware of these things? Some physicians prescribe antibiotics even for vital ailments since they want to earn a good name in the field. Antibiotics should not be taken too frequently as it paves the way for so-called superbugs, also known as antibiotic resistance. Some patients also do not complete the full course of medication, antibiotics, since they see improvement by taking these just within 2 days and stop the medication halfway through the course. In developing countries and underdeveloped countries, even banned medicines and fake medicines are sold. Another problem is fake physicians also. Even prescription medicines are sold without a registered physician's prescription, like over-the-counter OTC drugs. In developed countries, these events do not happen since the rules and regulations are strictly enforced. It's not that the rules and regulations are better. It's a change in the consumer protection. Consumer protection is so damn good. I wouldn't say that the people are good. Consumer protection is so damn good, so people fear the liability, considering the liability. So medical errors are a combination of multiple factors as explained. So a root cause analysis is a must to identify the most vital causes and seek remedies for them first. Apply the Pareto principle. ISO 9000 TKM system certification should be made mandatory besides ISO 14000 EMS and ISO 18000 OSHA certification for all hospitals, physicians, clinics, pharmacies, and medical testing centers. For your information, TKM is short for Total Quality Management, ISO for Organization for International Standardization, EMS for Environmental Management System, or OSHA for Occupational Safety and Health Act Administration. Cancel the license of hospitals, physicians, testing centers, and pharmacies and medical testing centers that violate the rules. However, besides heavy penalty for these perpetrators under the criminal codes, eye for an eye is the right policy, which will act as a deterrent for potential perpetrators. Zero tolerance is a way to go, since most of the medical mistakes are premeditated crimes. Corruption is the root cause of all evil in society, since people violate the rules attributed to their affluence, either financial or political, in society. Debates, discussion on open-ended topics like this can go on forever. Anyhow, let me pull the plug here. We'll meet again real soon with another interesting topic. Some of the statements, views expressed are solely mine based on limited knowledge gained over 6 decades of first-hand experience. Always watch these videos with the closed captions, subtitles for absolute 100% comprehension as per my sincere recommendation zillion times so far. I know I rushed through to complete the presentation within 20 minutes max, which is a norm that I have set myself to retain the viewer's attention. But I am also aware of the fact that I exceed this time limit. Sometimes I take double or even triple this time depending on the topic. Today I must have taken around 1 hour, triple the time, since I make honest attempts to cover the selected topic more elaborately, including so many intricate fine details referring a wide variety of sources, in particular Wikipedia quite extensively, besides articles and books published recently. Besides, of course, I sprinkle my own salt and pepper and season it with my personal experiences so far in my life and also intuition. Stay at home as much as possible to maintain social distancing attributed to the pandemic novel COVID-19 and prolong your lifespan. Lead a healthy life. God alone, God also known as the supreme power, is the one and only one who can put a stop to natural and unnatural, maybe biowar and cyber war events like pandemics and epidemics, which ultimately paves the way for apocalypse and extinction of all sentient species on Earth for no fault of theirs. Rest in peace and harmony. See, I have taken 15 minutes, as I said.